Hello, everybody. Welcome to this edition of the Asia Ventilation Forum, or AVF Podcast. This is the ICU Tips and Tricks series, and my name is Jason Phua. Today, we are really glad to have Dr. Anders Perner. Dr. Anders Perner is a senior staff specialist and professor in intensive care at Rigshospitalet, University of Copenhagen, and an honorary professor of the George Institute in Sydney. He chairs the Danish National Centre for Research in Intensive Care and a Scandinavian Critical Care Trials Group. He was the chair of 3 landmark trials, the 65, the 6S trial, the TRISS trial, and the classic trial. And the results of these trials have improved the fluid and transfusion therapy for patients with sepsis. And today, Dr. Perner is here to talk to us about how he provides fluid therapy in sepsis. So welcome again, Dr. Perner.
Thank you. Thank you. Happy to be here.
Thanks, Dr. Perner. Maybe I'll just start with a very simple and commonly faced scenario. You have a patient who's presenting to the emergency department with what looks really like sepsis. He's hypotensive. And generally, we would first start by, of course, checking the lactate, doing the blood cultures, giving the antibiotics, but we're here to talk about the fluids. And I guess my first question to you is, how would you decide on whether to give fluids for this patient right at the start and how much fluid to give?
Yeah, so that's, I guess, a very common scenario all over the world. And it's the at least seen from a management problem, it's still a challenge to clinicians and hospitals systems to provide the best care for patients with sepsis, and then therefore, I guess in particular for patients with septic shock, the outcomes are still poor, so high mortality rates for these patients. So it's very important that both doctors and hospital systems are prepared to handle these patients. As I said, for a specific patient, it's a challenge. If you go to the international guidelines, or the latest iteration of the Surviving Sepsis Campaign guideline, it's on the other hand quite simple. So if the patient has sepsis-associated hypotension, he or she is to receive initial fluid bolus of 30 ml per kilo. So I think a fair starting point is to start providing IV fluids. If there is no concern about potential cerebral pathology, I would start a buffered crystalloid solution. If there is concern about potential CNS involvement of some kind, I would give isotonic saline. So you start out and then try to chase the story for patient history for fluid loss. In my experience, it's actually quite few patients, in particular those who present in the ED, who have lost a considerable amount of IV fluid. If they have lost fluid by diarrhea or vomiting, and it's well documented, such a patient is likely to benefit from, in my opinion, higher fluid volumes. If there is no documented fluid loss, I would be of more concern. And particularly if the patient has pneumonia, so a hypoxic respiratory failure, such patients will be more prone to the side effects of fluids, which one of which is pulmonary edema. So in short, start out with IV fluids. For most patients, a buffered crystalloid. For those who may have cerebral pathology, IV saline. If there is a history of fluid loss, this patient may need a higher fluid volume. If there is concern about side effects, that could be pulmonary edema. For patients with pneumonia, these patients should likely have a bit less. After the initial start, repeated assessment of the changes in the patient's markers for hyperperfusion would be, I think, a valuable tool to, again, allocate patients to higher fluid volumes versus lower fluid volumes.
Right. Higher fluid volumes versus lower fluid volumes. We have all seen the guidelines, 30 mils per kg, as you said, of crystalloids. And yet, in reality, I don't think any of us actually just gives 30 mils of per kg of crystalloids just like that. We would give 500 mils, 1 liter, 1.5, 2. And you recently led the classic trial. Could you summarize the findings for us and how we should move ahead given the findings of your trial?
Yeah. So the classic trial was a randomized clinical trial done in 30 European ICUs in 7 countries. So it's important to stress that this was in Northern Europe, ICU setting, and most patients had already received the initial resuscitation. So most patients had received the 30 ml. So this is the sort of patient entering into the what could be called the stabilization phase. So after initial management. We then randomized patients to fluid restriction. So in essence, that was no more IV fluid at all, unless there were specific indications for it. And the specific indications in the protocol was, first of all, severe hyperperfusion. So if the patient, in spite of now the initial resuscitation, displayed severe hyperperfusion as either very low blood pressure, so mean arterial pressure below 50, in spite of noradrenaline, mottling beyond the edge of the kneecap, a lactate above 4, or a low urinary output. But the latter was only for the first 2 hours because patients with established AKI and no urinary output should not be harmed by repeated fluid bolusing. So if patients in the restrictive group displayed one of these markers of severe hyperperfusion, they could have a fluid bolus, 250 to 500 cc, and then be reassessed. The other specific indications for IV fluid in this protocol arm was if fluid was lost, so obvious fluid losses, again, bleeding, diarrhea, ascites, then IV fluid could be given. Or if they were or if IV fluid could be given to ensure a total fluid input of 1 liter per day, but this includes everything, so IV drugs, nutrition, any oral input as well. And actually, this was very few patients who had fluid on this indication. So the control group was standard care, so that was the Surviving Sepsis Campaign guideline, so continue IV fluids as long as the circulation improved. We followed the patient to 90 days. The protocol was active as long as the patient was in ICU, and that was a medium of 5 days. And in those 5 days, the restrictive group received a median of 1.5 liters, whereas the standard group received a bit more than double of that, a bit more than 3 liters of IV fluids. So the important endpoints was mortality at 90 days, severe adverse events at 90 days, and days alive without life support, and days alive and out of hospital. And none of these outcomes differed between the 2 groups. So the conclusion of the trial, the firm methodological conclusion, was that the IV fluid restriction did not improve mortality or any of the other important outcome measures. Obviously, the alternative conclusion is obviously that IV fluid restriction was safe. The addition of more fluid to these patients did not improve their outcome.
And so, given that finding, which direction would you shift towards? Because, as you said, it's both ways are correct.
Yeah. So I think, I mean, a pragmatic view on this is that we have sort of established a zone, if you may, a range of IV fluid management strategies that appears to be safe. So within the framework that we worked in a trial, so patients who had received the initial fluid resuscitation, who then in ICU received median between 1.5 to 3.5 liters of IV fluid, that appears to be a safe zone. So if you work within this zone, the fluid management is it's safe. It's not beneficial to give in the lesser range, or it's not on the other way around. It's not harmful to give at the higher range. If you move beyond this range, there's still uncertainty. So based on our data, we cannot recommend being even more restrictive, and we cannot recommend being more liberal. So I think a practical result of our trial is that we have sort of established a range within where the fluid volumes appears to be safe within this range.
Right. Dr. Perner, can I ask, in your opinion, does this change, you think, the validity of the 30 mils per kg guideline? Because on the one hand, the intervention arm was restrictive, which was compared against the guideline. But on the other hand, as you rightly said, patients, most of them had already gotten a bolus of fluid even before enrollment into the trial.
Yeah. So it doesn't challenge the initial 30 ml per kg. So in fact there are the results presented of 5 predefined subgroup analyses in the trial, and one of the subgroup analysis was for patients who had received more or less of the 30 ml at the time of randomization. And actually, those who had received less than 30 ml, if they were randomized to restriction, they appeared to do worse. So I think, and this is somewhat speculative because it's based on a subgroup analysis, and the results are not statistically significant, but just looking at the numbers, if you had received less than 30 ml and was randomized to restriction, so you overall received less fluid, you may have fared a bit worse. So 90-day mortality was 5 percentage points higher in this group. Not statistically significant, but still, without any other evidence, this is a sort of a signal, a hypothesis that our results at least do not support being even more restrictive, because the subgroup who overall in the full course of their sepsis was most restrictive actually did worse.
Right, got it. You mentioned just now that one of the indications in a restrictive group to give more fluids is mean arterial pressure of less than 50, and some of them are even on norepinephrine. So I was just wondering, in your practice, when do you start the norepinephrine as you are giving the boluses, after your boluses, etc.?
Yeah, so these patients had septic shock based on the new sepsis 3 definition. So all received vasopressors. So vasopressor plus lactate above 2. So those are the shock criteria on which everyone was enrolled. So everyone was on a vasopressor. So I started vasopressors for low blood pressure. So I think, at least in my quite simplified approach, and I think this has some value. It has value to do the care of these patients as simple as possible, because it's complex enough as it is, and therefore, if blood pressure is low, I give a intervention that raises blood pressure, and that intervention is noradrenaline. So I give noradrenaline for low blood pressure in principle without even considering whether or not they have had IV fluid. Because
right.
I don't think IV fluid is a good intervention for low blood pressure. It's a good intervention potentially against low cardiac output driven by hypervolemia and therefore other markers of hyperperfusion, and particularly modeling potentially raised lactate, but not hypotension in itself. For that, I give a drug that raises blood pressure, and that drug is noradrenaline.
Got it. Do you give colloids? Because the Surviving Sepsis Campaign guideline would say that after a decent amount of crystalloids, however you define it, you give some colloids.
Yeah. No. I as I see the literature, there is, I mean, 10,000 of patients have been randomized to albumin versus a crystalloid, and for now there are no conclusive evidence that albumin is superior to crystalloids. It's much more expensive, and the patients have capillary escape of albumin anyway. So what you give as an external source of albumin will be lost to the interstitium, and I worry a bit about that. So no conclusive evidence that it's beneficial. It's expensive, and it will escape the circulation anyway.
Right. So far we have talked about a bolus of fluid in a range of 30 mL per kg, and after that, somewhere between 1.5 to 3 liters. And in the restrictive group, we have talked about using markers like lactate, mottling, extremely low blood pressure, extremely low urine output. But we haven't talked about the usual markers of fluid responsiveness or preload responsiveness. When do you start using those, and how do you do it?
So in essence, I do not use them, except that a way to do it, I guess, is the traditional, the old school way is to give a fluid bolus and then to reassess the marker that you used to establish the indication for IV fluid. So I would see a patient with mottling or cold feet, and decide to give fluid based on that, and I'll give 500 cc, and then I'll reassess. So that's my assessment of fluid responsiveness. Obviously, I gave fluid to assess it. If the patient does not improve, I'll stop there. If there's no improvement in the markers that I found for indicating to give fluids, it does not improve, I stop. If there is improvement in that marker, I'll reconsider again balancing the risk-benefit for the specific patient. If it's a patient on a ventilator with pneumonia, I'll be more restrictive and then maybe stop. If not, I could repeat my fluid bolus. So I don't use any of the methods to assess fluid responsiveness without giving fluid. So pulse pressure variation or passive leg raising. So these are more complex techniques. They all need more advanced hemodynamic monitoring, either a PICO system or a tool to measure stroke volume. Many of the studies done are very physiological, so small group of patients only showing that you can identify fluid responsiveness. It doesn't show the consequences of the patients to have this fluid, so we don't know if it benefits patients to be resuscitated guided by the more advanced markers of fluid responsiveness. And in some of the techniques like echocardiography assessed stroke volume, that's actually pretty poorly validated. So I'm uncertain if echocardiography can be used to assess changes in stroke volume during passive leg raising, because you are to assess quite small changes in stroke volume, and I don't think that the studies assessing this technique have validated that you can use transthoracic echo to assess the small changes in stroke volume that you're looking for with the use of passive leg raising. So I want to challenge the methodology of the techniques, and more importantly, the lack of evidence that these more advanced, more expensive tools, higher resource use, that they will benefit the patient and the healthcare system. And again, I think simplification of care has a rationale in itself. So I try to do things as simple as possible. And if everyone in the team and everyone in the hospital does it the same simple way, learn this very well, I think this will improve overall care, and it is at least more cost effective than using more advanced methods that have some of them have not been validated, and none of them had at least have been shown to provide patient benefit if used.
Right. You've also been involved in some DeResuscitation work. When patients are hemodynamically stable, you start to dehydrate or diuresis or dry the patients. How do you do this?
So I, particularly if the patient is on a ventilator, I'll be very meticulous about restricting all fluids, also with obviously IV fluids as per the classic protocol, but also all fluids with the medication and even with nutrition to avoid fluid overload. Because I think there's a reasonable amount of evidence that overhydration prolongs the time on the ventilator. I mean, it may not worsen mortality, but it prolongs the time on the ventilator. And time on the ventilator is an important endpoint for patients and in particular for healthcare systems. So it complicates the care of the patient as long as he or she is on a ventilator. So I'll order negative fluid balances as soon as the patient is stabilized. So that would mean lack of signs of severe hyperperfusion. And again, my markers would be cold feet, mottling, lactate above 4. But they may still run noradrenaline. Many patients who still run noradrenaline actually improve their circulation once you take fluid off them. So running noradrenaline is no problem. So I'll order 1.5 liters negative fluid balance every day for these patients until the patient is sort of balanced based on clinical findings and on weight and cumulative fluid balance on the charged. Knowing that these markers are a bit less precise, so if I'm in doubt, I'll take 1.5 liters more off to try to as soon as possible get to a zero balance.
Right. Do you give 20% albumin for those with low albumin levels? No, you don't.
No, they have low albumin because it has left the circulation. If you give these patients albumin, this albumin you give will leave the circulation. So nothing's gained. Right.
Got it. Great. Thank you, Dr. Perner. That's a very comprehensive overview from the start to the end. Is there anything else you would like to share with the audience about fluid therapy?
No, I think it's still, and I guess that's why we are having this chat today. I think it's still fascinating and still quite challenging, maybe one of the most challenging medical tasks that we'll see, at least see in a reasonable volume in the emergency department, in the ICU. And therefore it's important that that we have sessions like this, that we continue to do research in this area, and that we sort of leave the dogma and let our decisions guide by the best available evidence, and in my opinion, that originates in clinical trials. Physiological driven hypotheses are fine, but at the end, they should be tested in a randomized clinical trial. That's the only way that we will gain the final knowledge about how to handle patients. And I think the dynamic markers of fluid responsiveness is a good example of that. It's a good physiological hypothesis, adding potential important information to a very complex clinical question, but it has not been assessed in a large trial, and therefore I don't use it until someone shows in a large trial that this provides benefits to patients and healthcare system, because it's more costly, more resource demanding, takes a lot of training to use it, at least to ensure that it's delivered 24/7. And until someone shows me that this has value, I will not use it.
So thank you for very wise words and a shout out for evidence-based medicine. And with that, once again, this has been Dr. Anders Perner, who's been talking to us about fluid therapy and sepsis. This has been the AVF podcast. You can find it on YouTube, Spotify, and please feel free to share it with your friends and subscribe and like. And we look forward to seeing you again in the next podcast. Thank you.
Thank you.